Dr. Jonathan Fenton, and I'm demonstrating prolotherapy injections under ultrasound for the hip. And so after I cleanse with gentian violet with chlorhexidine and then use sterilized probe and sterile gel, I look at the hip and have my pen ready to mark, and you'll see the femoral head, the acetabulum, the capsule, and what you want to look for is the neurovascular bundle, which in most people is at the inferior femoral neck, as it is here. I can use that pointer and show where it is. It's right down there and up there, because the circumflex femoral artery is there. But some people, it's right in your target, which would be here. So you have to find where it is to miss it. You can use color flow to make sure if you don't see it. And there it is, color flow. So after you've found the neurovascular bundle, the trick is to, if you can, get it off screen, get the apex of the femoral head-neck junction about mid-screen, and then short axis slide your probe till you lose it. And when you lose it and just barely get it, you want to be there, because where you think is dead center is actually going to be lateral, and you'll have to move your needle. So you want to slide it medially enough so you just barely get the white part of the femoral neck, and then I'm going to mark my spot. And that's for injecting the joint at the inferior femoral neck. The second place that you're going to look is you're going to long axis slide your probe superiorly till you see the femoral head, the acetabulum, and the capsule above it. And so that's cartilage, that's the capsule, that's the psoas. And so what you're doing is you're assessing the capsule, and you're going to, again, also in mid-screen, put the acetabulum to get the capsular ligament. So as I turn my probe to get more laterally, the arrow is in a little capsular labral defect, and I want to go above that, so I'm going to mark that. And then usually you don't have to make any other mark, but then you can, that's the iliofemoral ligament. As you rotate the inferior probe and go more medially, you get the more medial of the Y ligament, but you have to not mark there because you have to know where the artery is. So I'll turn the probe short axis. So there's the femoral artery, vein, and nerve. And so you want to make sure you are lateral to that. And so I want to be walking from lateral to medial instead. And then lastly, you can look at the pectineus, which is under the neurovascular bundle where the arrow is. And sometimes you need to get that as well, but that's a horizontal approach through the psoas. You go below the neurovascular bundle. So to summarize, one spot to go to the inferior femoral head, another spot to go to the iliofemoral and pubofemoral ligament, and then you can, of course, inject the psoas in plane or transverse.
If you like our educational videos, click the link below and join the American Academy of Orthopaedic Medicine. As a member, you will have access to some of the best regenerative medicine education in the world. AAOM has been offering live and cadaver workshops, national and international conferences, teaching doctors prolotherapy, PRP, stem cells, and more. Become a member today and take your regenerative medicine to the next level.
Always remember to get all the air out of your syringe or you won't be able to see your image. I use buffered 0.5% lidocaine for numbing, 3-2-1, and I use a 27 gauge needle. In bigger people, I use a 25-2. I warn people that sometimes they could get a little electric zinger. Even though you're missing the neurovascular bundle, some people have little tiny branches you can't see, but nothing happens. So then after it's numb, in most people, depending on their size, I use a 70 by 70 millimeter needle or a 22 gauge 2 3/4 inch needle. Some people you need a 4-inch. Dr. Bond in Louisiana says you need a 6-inch, but that's where he lives, not where I live. And so after I visualize again the neurovascular bundle, which is on the right of the screen, and then I stretch the skin to get it out of the way, and I'm just medial, as I put the needle in, I watch on the screen the angle of approach. So it's heading for the superior femoral neck. So you'll see the needle go in, and just because you think you're there, that's not good enough, because you need to be dead center on the femoral head for it to flow properly. So you need to turn your probe 90 degrees, and then by gently tapping, you're going to follow the needle from superficial, now I'm in the middle of the psoas, to deep, and you'll see the needle moving right to the right of the arrow, and I am a little bit medial. So I'm going to change that, and I'm going to walk it a little lateral to be right in the center. So you see the needle tip's pretty much top dead center. Needs to be there at more or less 12 o'clock for it to work properly. And there's my needle, and now you watch the flow. You can put on color flow to see it flow. Put on CF, please, at the needle tip. And so if you're unsure if it's going, you can see if it flows inside the joint. And so you'll see fluid flow, but you'll also see the little Doppler at the tip. And if you watch, it'll flow up. Turn off the color flow. And so what you want to see is that the fluid eventually flows from the inferior head up and over the femoral head. Nice and slow. I usually use about 10 cc's. And you want to see that it's not going into the bursa. So I don't see any flow out of the bursa. I'm waiting for flow up on the top of the ball, and it's starting now, and it usually starts at about 7. So if you look to the left, you'll see it flowing in the inferior femoral neck, but I'm waiting for it to go superiorly, and now it is. Right here, you will see the cartilage interface sign, which is that there's fluid going there. So you'll see the cartilage interface sign rise, and you need to put enough fluid to see that happen. If you don't use that volume, it's not going to work. And the reason it's not going to work is you got to get fluid up to the top of the femoral head. So that's intra-articular. And the trick that I do is in people who have what appear to be, if you will, frozen hips, or hips that have capsular restriction in internal rotation, adduction, and extension, if you put as much fluid as you can in that, I usually aim for 20, very slowly, and wait for it to go numb, you can mobilize the hip, restore their motion, and get rid of their pain. But you have to watch it flow. And a reminder, the only anesthetic that is non-toxic to joints is ropivacaine, 0.1%, 0.2 or less. Bupivacaine is toxic at any concentration. Lidocaine is toxic above 0.1%. So please remember to use ropivacaine. The next thing I'm going to do is do the capsular ligaments above, which in a lot of people who have minor hypermobility of the hips or who have had bad falls, and equestrians and snowboarders as well, they get damage to these ligaments. They'll be thick, they'll be spongy, and when you put fluid in them, it expands. As you can see, the black is where the fluid is that I put in her joint. Cartilage interface sign showing that there's fluid, therefore shows the cartilage. And what I'm doing is I'm stretching her skin, and I'm moving the probe superiorly to go where the arrow is to look at the capsular ligaments. So there's way lateral under the arrow, and then as I go medial, so I'm going to go somewhat lateral to start as my point of entry, being careful not to actually put a needle in the labrum so you don't damage it, unless you see a tear, and then you can gently put a needle in. 3, 2, 1. So you'll see my needle tip aiming to the arrow, and the goal is, again, not to go in the labrum and not to go in the joint. Now, I have done this procedure on people who've had hip replacements who have psoas and joint capsule problems, or effusion, or seromas. So once I'm down into the capsule, I can inject a little fluid, again, getting air out, and it opens up, and so that capsule is kind of loose. And then I can walk the needle medially, because now by walking the needle medially, I'm not going to be near the neurovascular bundle, and you got to not put the needle through the femoral artery. People do not like that. So I'm taking the needle out, moving it a little medially, walking my needle a little more medially above the acetabulum, injecting a little bit. And then I can walk it a little further, pull it back, blow it out. And then I can walk to the pubofemoral ligament, but usually it's iliofemoral that needs it. And obviously I can go to the psoas, which is just above the needle, if I so choose. So there's the capsular ligaments, medial to lateral. If I go transverse and see where my needle tip is, in short axis, you'll see my needle tip is right by the arrow there, and then I can pull it out and walk more medially. And if you want to get to the pectineus, which is rare, you have to go completely transverse through the psoas from the right side of the screen to the left under the neurovascular bundle. Rarely needed. So that's the anterior hip. What I didn't do is the inferior capsule, which some people need if it looks bad. So you see where the black fluid is, and so the capsule is above it where the arrow is, but it is in perfectly good shape. But if I wanted to treat that, I would have to, again, look for the neurovascular bundle, which is, turn on the color flow, which again in this patient is inferior, and I want to plan my needle path to miss all that stuff. So I go from superior to inferior under that part of the neurovascular bundle. And again, an important point for using Doppler is many people, their neurovascular bundle is right in the middle of your needle target. And that's why I use ultrasound and not fluoro, because I would say it's 10% of people, I would be putting the needle right through the neurovascular bundle to get to the classic superior femoral neck. And when you do that, people get paresthesias, and sometimes they'll get numb into their quadricep to their knee for 3 days, 3 weeks, or even 3 months if you really do a good job. So that's why ultrasound's a better tool. You'll notice I'm using a linear probe. For most people, it's good enough. You can use a curved probe, but make sure to do both long axis and short axis imaging so the fluid is in the right place. So that's the anterior hip. It's angled from the ASIS towards the mid-trochanter, and you'll see the facet of the minimus, and above it is the medius, because the medius is much bigger. And if I long axis slide, you'll actually see the black of the fluid that I put in her hip. So that's intra-articular. So now you know where the capsule is, which is very handy. And so that's inside the capsule, and this is the capsule. This is the tendons, okay? So I'm aiming for a mark where I get the capsule from one angle and the tendon from another. So that's anterior. Dead center is where a lot of people have pain, and so when I'm looking at the facet of the greater trochanter for the medius, you're seeing it off axis, but you're looking for slight cortical irregularities or thickenings, and you really want to aim for those. So right above my arrow, I have a little white dot of a little irregularity, and then there's a tiny flat area here where the medius is a little damaged, so I'm going to mark that. And then a lot of people have more symptoms, especially if they have back problems, at the posterior facet. And that's the angle where you really see the medius properly, and the whole thing comes over and attaches and crosses over. So here, there are a lot of cortical irregularities, which in Vermont is called falling on the ice often and hurting yourself, but in the South it's called you have a bad hip. And so you'll see all those cortical irregularities, and you want to try to needle them as you inject, because slightly excoriating them when you're using dextrose is better. If you're using PRP, you really don't need to as much, but you do need to pepper them. If I go short axis on the probe, you'll see the 3 facets: anterior, middle, posterior. So you get all 3 facets, and then you can see those cortical irregularities that you want to hit. I'm not going to cover the piriformis in this view because there's a trick you have to do to really see it properly. lastly, on the side of the hip, or not lastly, you'll see the iliotibial band crossing over, and a lot of people have an enthesophyte right where the arrow is. And that's where you'll see bursal fluid and issues. So it's always worth getting that as well. So that's a mark a little lower down to get the apex of the posterior facet. Capsule-wise, we make the image a little deeper, and here's where a lot of people, you'll need a curved probe. Keep going. With this particular machine, with virtual convex, you can actually see the capsule quite well. So where the arrow is her lateral hip joint, and the capsule's right above it, and there's no issues here, but if I was going to inject, I would mark up here and inject superior to the acetabulum, which I will probably demonstrate. So that's, I saw someone this morning who that capsule looked like a sponge, and as I moved their hip, the ball slid lateral and medial. It's not supposed to do that, so that's an unstable capsule. Then if I go posterior lateral, that's also capsular ligament. And it's essentially the same thing. You're just walking from anterior lateral to mid-lateral to posterior lateral, and you just see if there's capsular thickening or cortical irregularities. So, pause. Tell me when you're ready.
Action.
A little darker. So I cleansed twice with ChloroPrep, sterile gel. There are no vessels to worry about here, but you can always use color flow to check. And I've got my target where my arrow is. And in this case, I'm using a 25 gauge 2-inch needle. And remember, try not to bend your needle because then you'll lose it. And the trick is to look down at the probe and your needle, and before you go anywhere, put the needle under your probe before you look at the screen. And then when you look up at the screen, it should be there, and then you can do little short slides. So there I am going for that little white dot. That's a little irregularity there. And so once I got it, I can put fluid in it. So there's my needle at the dot, putting fluid in. And then I can pull back and go a little more superficial and get from bone back into tendon. And then again, try to go, after you have it long axis, to go short axis second, not first. And as you sort of lift and glide, or as Dr. Brown said, give a little puff of fluid to see where it is. So you'll be fooled because of volume averaging. Are you dead center? So here I am, but if I want to walk more anterior, I can pull back and move the whole needle, not bend the needle, and then wait for my tip. And there's my tip coming in a little more anteriorly so I can pepper it. And this is very important for complex and thick tendons like the rotator cuff or the hip. And I can do the same thing, pull back without bending the needle, pull way back, go back down knowing the angle, and now I'll be posterior. Now I'm over here. And you can watch the fluid flow to see how it opens, and that's a little loose. And you'll see the fluid flow to the right, so that tendon's not the happiest. And you just do puffs and fenestrate against the cortical irregularities. So I'm trying to get in, and what you'll find if you find these little cortical pits is you can literally get in them, and sometimes you'll be intraosseous even, especially in the shoulder. If you really aim carefully, you can get right in them. And that's usually the enthesopathic problems, and I bang on it a little bit, politely. Then, so that it's the same for the minimus, which is that step off right there. 3, 2, 1. So again, I'm looking down to make sure my needle's under my probe first before I look at the screen. So there's my needle. Right, I'll try to get the arrow there. So now that I've got my depth correct, and I put a little in, you'll see it flow to the left. And I'm going to go short axis. Little motions to see where it is. Move the pointer a little bit. So there it is on the surface above the pointer. And there it is deep. And again, I'm trying to aim for that little cortical irregularity right there. You can see the point. Inject. And this is taking very little fluid, so it's a much happier tendon. And then again, I can pull back and go one way to get a little deeper towards the left here. And pull back and go a little to the right. There. Okay, and then we're gonna do the one more part, which is the posterior facet, where she's got that cortical irregularity. 3, 2, ow. And I put my needle down and I'm pretty close. Inject a little bit and then change the angle so I can get that cortical irregularity. And then go short axis to make sure I'm accurate. So you see the needle tip is just to the left of that cortical irregularity. So I'm going to pull back. And now if you can see it, I'm right on it. And usually at those cortical irregularities, you'll get more fluid flow because the tendon's a little less competent. So I'm going to go a little to the right to get right in the middle. And you'll see fluid flow. So that's the facets. And lastly, it's the same structure, but now I'm on the posterior facet where there's that ITB gluteus maximus interface. And you can needle that as well. 3, 2, 1. That's the one people don't like, because that's why you want to get it, because it's a pain source in a lot of people. If things are really junky, you do have to do a lot of needling. So now I've gone to the sacral notch, which is to the left of the arrow, and just next to that is the sciatic nerve, and put an arrow on the sciatic nerve right in the middle there, that giant thing there. And then if you go superiorly, you'll see a bright white echo, tiny piriformis above it, so go up an inch. Keep going, keep going. That's the piriformis, and the way you know it is you have to find the sciatic notch, and then as you go laterally, I've never had to inject the piriformis. I don't think it's needed. It's usually L5 nerve root problems, but it attaches to the underside of the trochanter, and there's the trochanter. More importantly, and more common a pathology, you'll also see that below my arrow is now the hip capsule, posterior hip capsule. So the sciatic nerve is right above my arrow, and there's the posterior hip capsule, and that's why you can't inject there unless you really are careful, because you don't want to hit the nerve, and there's also some arterial stuff there. So when you want to do the posterior capsule, I'll show you the trick in a minute. So my assistant's going to take her leg, bend her knee, and internally rotate by moving her foot out. If the foot comes towards him, just bring it all the way towards you, then the greater trochanter is approximating the ischial tuberosity. If it goes away, all of a sudden I got lots of room to work. So put it all the way into internal rotation. I got lots of room to work. And now I can inject under there easily, missing all the neurovascular structures, because if I use my pen, I can mark up here, and as long as the leg is internally rotated, you can get under the shelf of the trochanter to get the piriformis, the gemelli, the obturator, all the way down. So that's kind of the trick, and you really need to do that. And I'll show in a minute what you do with the needle and the probe, but I'm going to go back towards the midline, and I'm going to get to the superior part of the ischium, which is right there. And when you get to the superior part of the ischium, what you want to see is a muscle that, strangely enough, goes up and over it, a tendon, and that's the obturator internus. So as you move the leg, internal and external rotation, you'll see a tendon sliding up and over it, and that's the obturator internus. So it comes up from the pelvis, takes a right angle bend around the ischium, and goes out to the greater trochanter. And that is a very common problem. And the way you inject it is at the apex of the ischium by bringing the needle from medial to lateral, but you have to be very careful because where my needle is now, there's going to be neurovascular bundles that you have to watch out for. So that's how we're going to get the obturator. I'll show that in a minute. And then laterally, there's the rest of the obturator and the gemelli. And finally, that last muscle is the quadratus femoris, which is past the capsule. So I'll show now how you get these muscles and how you can safely get the posterior capsule without worrying about the nerve. The interesting thing about the obturator is the sciatic nerve sits on top of it. So the piriformis, the sciatic nerve, is below it. The obturator, the sciatic nerve, is above it. And if the obturator gets thick and unhappy and junky, the sciatic nerve could get pseudosciatica. So the sciatic nerve is now immediately above my arrow, and it's very flattened there. And that's normal. But if the obturator makes that nerve bounce up and down when the obturator moves, then you can get pseudosciatica. And it's actually very common and very easy to treat. All right, so back to the obturator. As you see the tendon move left to right, so now go into external rotation, which is internal, I'm sorry. And just put it and leave it there. And now I'm going to try to put my needle right on the top of it. And if you aim for the very top, you will not hit the neurovascular bundle. So as I advance my needle, turn on the color flow, please. I'm making sure, so there's a vessel right there, so I want to miss that. See the needle tips near the vessel? So I'm going to back up and I'm going to go under. Okay, turn off the color flow. So now I put my needle in right under all that, or any vessel that's there. It's not typically there, it's usually more medial. And then as I inject, it'll flow into the obturator. And you just pepper the area so you get flow. And if you look, you'll see it flow into the obturator. And again, the sciatic nerve is the flat structure right above the obturator. Arrow and dead center. A little lower, right there. That flat structure there is the sciatic nerve. All right, so now we're going to switch to where it's more important for most people who have hip problems, is here. So a little deeper. And so now we're going to get the posterior capsule. Turn on the color flow. We'll see where we are. And so I have the Doppler color flow on to make sure I don't have any atypical vessels in my way. And where I'm aiming is under the shelf of the greater trochanter with the hip in internal rotation. And then I can get there. So 3, 2, 1. Turn off the color flow, please. So then there's my needle coming down very close to the trochanter, so I'm nowhere near any neurovascular bundles. And now I can get it into those tendons, which is there, but I can also get it into the posterior capsule if I just walk a little deeper. So what you see is I have the probe flat, not following the curve superiorly of her buttocks, but pretty flattened, so I can see the needle. And the leg is internally rotated, which means my assistant has the patient's foot out lateral to the body. And so that way I've exposed that undersurface where you can see all the muscles and tendons and work them off. And then that's how you get the posterior capsule. You really can't safely do the posterior capsule at the acetabulum. There's a way to do it, but I don't recommend it because it's very easy to lose your bearings and go near the geniculates, the gluteal arteries or the sciatic nerve. So lastly, I'm not going to inject it, but this is the hamstring. So I have the probe long axis to the ischial tuberosity, and you angle the probe to get the hamstring level. You'll see I have it on virtual convex to see more of it. And everybody has slight irregularities in their ischial tuberosity. What you're looking for is irregularities in the hamstring and really bad irregularities in the ischial tuberosity. So I sweep from lateral to medial, and as you go up and over on the ischial tuberosity, you'll also see cortical irregularities. And above it is the maximus. And when I go short axis, left being medial on this picture, the hamstring is the perhaps 2 centimeter layer above the peak of the bony process. But what I want you to look for when you do this is you can't be dead center, because you have to look for, pause. So you do want to make sure after you get the needle in long axis that you check your short axis orientation, so you go from lateral to medial. And if you get too far medial, you're going to be near the sciatic nerve. And the other tip is to look for the posterior cutaneous nerve of the thigh to make sure it's not in your injection field, which in this patient it is not.